you so much. My name is Tiffany Grunwald, Executive Medical Director of the Women's Health and Wellness Institute. So we welcome your input on this, but we're doing this more kind of as a panel now without PowerPoint. I'm checking for chat questions, so please feel free to put those in there. This is from the Women's Health and Wellness Institute. All of our previous webinars on bone density, on sexual wellness, on hormone balance are all on YouTube, so please find those and share them. There's just a lot of great information, and we have so many amazing physicians that are part of our Women's Health and Wellness Institute at St. John's. Tonight we have Dr. Rebecca Lane, who's a urogynecologist, and Dr. Claudia Sanmiguel, who is a gastroenterologist. They are both experts on incontinence of many varieties, and we're going to kind of talk about all of that. Dr. Jen Linehan, who's a urologist, is still in the operating room, so she may join us later. And Dr. Tracy Childs, who is on a medical mission in Guatemala but is trying to sign in, will also be here to talk about this. But we're going to kind of start off with some questions and see where it goes. So we'd love to hear your questions as we go through. But I think, you know, an important part about starting this conversation is what's the definition of incontinence? Who has incontinence? What kind of patients? So I'm going to turn this over first to Dr. Lane, and then we'll go to Dr. Sanmiguel to talk about that. So Dr. Lane, can you talk about incontinence in your practice and who has it and what the definition is?
Yeah, absolutely. So my practice is only women, so we'll talk about women, and I see urinary incontinence. So really there's two main types of urinary incontinence. One is called stress incontinence, and that's like if you're sneezing, jumping, exercising, and a few spurts of urine come out. That's that's stress incontinence. And then the other common type is urgency incontinence, when you have a strong urge to go and it leaks out before you get to the bathroom. So any involuntary leakage of urine is by definition incontinence, but only if it's bothersome to the patient do we, it's not dangerous in any way. It's not necessarily going to get worse. Sometimes it does, sometimes it stays as it is. So we offer treatment, really, we let that be guided by the patient's desire and bother.
And before we go on to Dr. Sanmiguel, can you talk about what percentage of women have incontinence?
Yeah, it increases with age. So
Damn.
I know, like all good things. There's a spike kind of in the postpartum period, just because of what happens with the pelvic floor after pregnancy. And then there's another spike around the time of perimenopause, menopause as hormones shift, and then it continues to progress. So among women in their 80s, it's up to 80% of women really who have some degree of incontinence, 60 to 80%.
Okay.
Yeah.
That's a lot of people.
It's a lot of people.
That is a lot of people.
And Dr. Sanmiguel, what kind of incontinence do you deal with?
So for fecal incontinence, it's basically the same involuntary leakage of either gas, liquid stool, or even solid stool. And usually it is more frequent in women than in men because we had pregnancies, deliveries, and gravity and menopause changes your pelvic floor. So it tends to be more frequent after 60, even worse after 80. And it depends of many factors. So sometimes it's the sphincters not working fine or the pelvic floor not working fine. But in some people, the sphincter is fine, but they have severe diarrhea and they can have incontinence. So incontinence is not just one disease, there are different types. And we usually classify passive incontinence when the person doesn't notice that they are passing gas or soiling their underwear. they just feel that it's wet, or when they go to the bathroom, they feel, oh, my underwear is soiled. Versus some people that is like, oh my gosh, I need to run to the bathroom if I'm not going to make it. So those are kind of the most kind of symptomatic classification, but the pathology under that might be different things. It could be your sphincter, it could be diarrhea, it could be your rectum that is not in the right position, or is inflamed and it doesn't have what we call compliance. So basically with very little stool, it's already full and then it's pushing to get out. So there are different ways to approach, and talking about frequency, most women are ashamed of talking about incontinence, and that's why we don't have good numbers. Our estimate is that about 10 to 20% of the people or women after 60 might have fecal incontinence, but it could be higher than that because people don't talk about it.
It's interesting because I feel like finally we're talking about urinary incontinence in a much more open way, and then the fecal incontinence, or leaking stool, is just coming out, right? Like it's probably 10 years behind. 10, 15?
Probably even more. It's like a taboo. People are ashamed that they cannot hold gas or they cannot hold stool. And that is so limiting for their lives. They don't go out because they don't know if there is a bathroom close by when they need it. And they are going to have an accident in front of their family or in front of their friends when they are having some social gathering. So many people become really
Closeted, yeah.
Yeah, sorry.
No.
And they are ashamed to talk to their doctors, especially they are male doctors. They are even more hesitant to bring this to
Someone who can help, right?
Exactly.
Yeah.
And we can help.
So maybe we'll go there then now, and we'll start with Dr. Lane again and then come back to you. But so,
What if you call me Claudia only?
Only Claudia? I like Dr. Sanmiguel.
Yeah, well,
Okay. So as we talk about this, and I think, especially with urinary incontinence, there was so much media push around slings and mesh. And so even when we started talking about it, then people were afraid. So can you talk about when someone comes in and the different surgical and non-surgical options that are available for them?
Yeah, absolutely. So I think it's a really important thing to talk about because you're right, even if women are a little bit more comfortable bringing it up, sometimes they just feel like, what's the point? Because they assume there really aren't any good treatments available, especially because of all the scary things that they may have heard about mesh. So again, back to the two umbrellas. So urgency incontinence, which is associated with the urgency, frequency, waking up at night to go, is not even treated surgically. So this is an issue where the bladder muscle is overactive and it's contracting. It's not waiting for the brain to send a signal down, okay, I'm on the toilet, it's appropriate to contract. This is just the bladder muscle contracting on its own. So we treat that. First line treatment actually consists of behavioral modification. So it's pelvic floor physical therapy. It's also modification of maybe the timing of fluid intake. And it's actually a very successful thing is just bladder retraining. So literally telling people to just space out their voids and helping them do that by tightening their pelvic floor, working with physical therapists to kind of space out the time between their voids. If they're going every 30 minutes, then we'll tell them, okay, this week, just go according to the clock and hold it for 45 minutes. And once that gets comfortable, hold it a little bit longer.
Because sometimes when they go, they feel like they really have to go, but they just pee a little bit.
Exactly.
So it's like, okay, then you can hold more. Right?
Exactly. So I think that's also a fallacy that some women were told as kids, if you hold it, you're going to get infections, it's bad for you. And I try to reframe that. The opposite is true. It's the more your bladder gets used to being empty, the more uncomfortable it's going to feel, even when there's a normal amount of urine in there. So it's kind of being able to tolerate it and not be scared. Now, some women are leaking, and so they start going to the bathroom more frequently because they're afraid if there's any urine in there, they're going to leak. So if the behavioral modifications don't work, then second-line therapy are medications. And so the medications for overactive bladder got a terrible rap because they caused terrible dry mouth, constipation. So lots of people who tried those medications in the past had really bad experiences and couldn't tolerate them. There are newer medications now that are very well tolerated and very effective at helping women hold the urine, feel less of that urgency frequency, wake up fewer times at night to go. So the medications are quite effective and pretty well tolerated.
And better now than in the past.
Better tolerated. So that's a fantastic advance. And I have to say, even since I started practicing 17 years ago, we have so many more tools in our toolbox to offer women. So those who don't do well with the medications, we go on to third-line therapies. So we do Botox injections in the bladder. We borrowed something from your world. We got smart because, again, it's the bladder muscle spasming. So it's an in-office procedure. It takes, 10 minutes for the procedure once the patient is numb, and we inject the Botox into the bladder muscle, and it stops this overactivity. So it's something that is very effective, and then they come back for repeat injections between 6 to 9 months. So that's one option, or we have nerve stimulation. So InterStim, it's a sacral nerve stimulator. So there's one version that's implanted, surgically implanted. Like I said, it's like a pacemaker for the bladder that's implanted under the skin. And now we have a version that we can do in the office. It's 12 weekly treatments with a tiny little needle that just sits right behind their ankle. They sit here, they read a book, or go on their social media for 30 minutes every week for 12 weeks, and that's pretty effective as well.
So there's a whole stepped procedure.
So that's the stepwise thing, and truthfully, sometimes we layer them together or whatever. So that's all for urge, incontinence, overactive bladder. So when you're not making it to the bathroom in time, leaking out before then, or just having the urgency frequency. The other category that we talked about, the stress incontinence, that's more about the pelvic floor getting weak and the urethra and the pelvic floor not being able to hold the urine in. So it's not a bladder muscle issue, it's a pelvic floor outlet issue. So that's when you're running, jumping, coughing, sneezing, and a few drops squirt out. The gold standard treatment is a sling surgery. It's a permanent mesh sling. It's a 30-minute outpatient procedure, highly, highly effective. 90% of women are cured or improved significantly. And that mesh got a really bad rap, but that mesh is actually safe. There are statements about the safety. However, for women who don't want to have that, pelvic floor strengthening is very effective. Working with a physical therapist or on their own, that is very effective. And we also have injections in the urethra. I call it filler. We do inject again, stealing from you, yeah. So we inject a bulking agent into the urethra to kind of help it coapt and keep that urine inside. So that can be done in the office or in the surgery center. Again, 5-10 minute procedure, very effective. So we have a lot to offer. So this fallacy that it's just a mesh sling or nothing is really not the case.
Do they have different mesh types?
We use just a standard polypropylene macroporous mesh. It's similar to what general surgeons use for hernia repairs. It's not the material that's a problem. It's kind of had been used in ways that that weren't ideal as far as repairing vaginal prolapse. And because the way it works is it's like a scaffolding for your scar tissue to grow in through that, and it reinforces the support of the urethra. So when people were using mesh to reconstruct the vagina, then their whole vagina was becoming just a mass of scar tissue, which is, the vagina is supposed to be stretchy and not stiff.
So that's good. I have some questions for follow-up, but let's go to Dr. Sanmiguel, Claudia, and talk about what your process is when someone comes in with fecal incontinence.
So we need to figure out what is kind of the major driver. And usually it's a multifactorial process. There are problems with the muscles, sometimes with the nerves, and very frequently, actually, people are eating the wrong things that cause diarrhea and it causes incontinence. So people taking a lot of diet sodas or candy. I have a patient, a guy, bought the Ricola candy, ate half of the bag every day for a few days, and he had the worst diarrhea and incontinence ever. As soon as I was like, why are you eating that Ricola or having that Ricola? He stopped, diarrhea was gone, incontinence was gone. So you have to check what are you eating. So anything that is sugar replacement or very difficult to digest sugars is going to cause diarrhea, and it can cause incontinence. Even if your muscle is just slightly weak, but if you have diarrhea, then you are not going to be able to hold it. So change that. The other thing, add bulk to the stool. So it's easier if you have to retain solid stool or something that is foam than liquid stool. So you want your stool not to be mushy or liquid. You want to have something that is more normal consistency. Check your medication. Some medications can cause diarrhea. And once we check that there is nothing in the diet and in the medication that we need to change, then we have to evaluate what is the mechanism. So is it that you don't feel it and then you have the passive incontinence? So probably the sphincter is not working that fine, or the nerves around that area are not controlling the sphincter quite right. So we can do an procedure that is to measure the pressures and see how the sphincter squeezes, how it relaxes. And if we find that it's weak, then you can do exercises. There are electrical stimulators and other treatments that we can talk about.
So very similar with doing pelvic floor physical therapy and e-stim.
Because the same nerves that control the bladder control the rectum and the anal sphincter. So since that worked for Rebecca in her patients, work for my patients as well.
Interesting, okay.
So, and many of my patients with fecal incontinence, they have also urinary incontinence because there is a pelvic floor dysfunction. And pelvic floor is a whole thing. It's not...
Can you guys talk about that? Because I feel like we talk about pelvic floor and we understand the anatomy, but it's a bowl of muscles that holds everything up. And I think people don't really understand that. They just think it's organs down there. So can you talk about the pelvic floor and
what is the... Okay.
Just in a layman's terms, how do people understand that it's just a whole bunch of muscles down there, right?
Yeah. So there are muscles that are just there to give the external holding, but there are internal muscles that help to keep the organs in place or give you continence. And the issue is that if the muscles start to get lax, they are stretched out, the organs change in place, and then having continence is more difficult because you are in different angles, you are not holding your organs in the right place. So that's why pelvic floor therapy works really well, because it strengthens all the muscles. And forget about the old school kegels, just your anal sphincter doing this, or you need to be strong everywhere. Your core muscles, your sphincter muscles, the sling muscle that gives you continence as well. So when you want to do physical therapy, you just don't want to concentrate in just one muscle. You want to strengthen everything. And it's also one of the reasons why when you are sedentary and menopause comes and the estrogens go down and then the mucosa is less plump,
Yeah.
everything tends to leak more because all the muscles are weaker, the seams are less, they close less tight than before, and then you have the incontinence. So you want women doing pelvic floor exercises, yoga, core exercises, so all the muscles get strong and everything works better. So usually I tell my patients not to do the little kegel, do slow squats, hold down, hold up, do the shoulder bridge and hold your pelvis
Do
up.
the shoulder
Bridge exercise.
Oh, yeah.
That one that you lay flat on your back, you bend your knees, your hip is standing like resting on the floor, and then you
lift up.
lift
Yeah.
up, just straight, don't overreach, and still don't go up and down right away. Just hold it for 5, go down, up, hold it, because that gives you stamina. If you just go up and down, it gives you some strength, but not much stamina. And you need stamina to be able to walk to the bathroom, holding
it. Yeah.
it.
Holding those muscles.
Exactly.
Yeah.
So I think I got lost in the answer,
No,
but
it's okay,
basically,
I think that's helpful. And again, if you guys have questions, please put them in. Can you guys talk about what the average time is for someone suffering from incontinence to get to you?
ooh, I think it used to be years and years before people that had symptoms will finally go to the doctor and ask for that, and then many doctors will be, I have no idea what to do.
Just where it depends.
Exactly. Exactly. So now I think more primary care doctors are aware that there are treatments for incontinence, so we get them a little faster. And usually when some of my patients come from irritable bowel syndrome with diarrhea or with constipation, I always ask for, can you hold your bowel movements? Do you have any leakage when you... And I ask also for urinary incontinence because it's very frequent, the two combined. So I think people are getting wiser in that it is not a taboo topic. It's not something that you should
Is it the patients that are getting wiser or their primary care doctors that are getting wiser?
Both.
I think both.
Yeah. What
But
about you? How long does it usually take?
You know, I feel like younger women tend to be more comfortable talking about these things, and they tend to come in sooner. By younger, I'm saying like maybe 40s to 60s.
Right.
I think the older women might still have the mentality that it's just part of getting older. It's just something I have to live with. There's nothing that can be done about it. And I always tell my patients, talk to your friends about it. If you're like brave enough to come out and say it, everyone's going to come out of the woodwork, like they all have it too. And so it is. But I certainly have patients who've, been suffering with it for years because it is kind of a under-discussed thing, right? But certainly I do think primary care doctors and specialists are doing a better job of screening for it and making it a little bit more discussed in places like this.
And I think also there was a big group of women that before nobody paid attention and now they are paying attention to, is postpartum.
Yeah.
After delivery, many women have urinary incontinence, and women that had a prolonged delivery or they have to use forceps or the kid came with the shoulder, the baby
Right.
came with the shoulder, or they are not young mothers, they have more tendency to have fecal incontinence and damage in the anal sphincter during delivery, and they start to have some fecal incontinence. And then usually it gets better when you are young, but a few years later, it comes back because menopause hits,
Right.
gravity
But you have that
hits.
damage in there.
You
Yeah.
had that damage, but you were young, you had good estrogens, you were active, you were able to cope with it without symptoms, but as soon as the symptoms start to.
Yeah, so for, I mean, both of these types is obviously more helpful, and we definitely try to get all of our postpartum women into the pelvic floor physical therapy so that they're just aware of it, right?
And as you know, I mean, in Europe, postpartum physical therapy for the pelvic floor is routine and covered because it's understood that the preventive value of it.
So you say it's covered in Europe, but it's also covered here.
It is covered here, but I think there is not a culture of
It's not a routine
sending
postpartum.
the patients
yeah.
for that.
Yeah, we're trying to change that.
Yes, exactly.
We're trying to change that. What about what other like integrative medicine therapies go along with this? I mean, you guys both talked about people being kind of shut-ins when they have incontinence. So that's probably mental health. Does nutrition play a part? Does acupuncture play a part? I know part of your practice is herbs and supplements. Like, what other things go along with this?
So nutritionists, obviously, I talk about all the non-digestible sugars or sugar replacements. Fiber is super important, and we have a society that eats so much processed food and very little fiber. Like some kids don't even know what like a vegetable looks like. It's just everything comes in cans and things like that. So nutrition, super important, and it's going to help you not only to have better continence, a healthier colon if you have better fiber in your intake. People with fecal incontinence and also with urinary incontinence, they have very limited social life and they get depressed quite a lot. I have patients that they used to spend the whole day at home, not going any places. They didn't want to meet with friends because they didn't know when they were going to have an accident and embarrass themselves in front of other people. So give those patients the social support until the treatment gets them to a better place is super important. Also give other coping mechanisms, because sometimes we can help them to improve, but still there are going to be some times that they are still might have an accident, so how to cope with that, how to be able to balance that and say, okay, this was just one time in so many days. I can still go out, do things, and prepare for this and know how to prepare for that.
Mm-hmm. Yeah, I agree. I think that's really important. I want to make sure that my patients hear me when I say, we're trying this. If it doesn't work for you, this is not the end of the road. There are other things that we can also try. So just making sure that they remember that and are open to coming back and understanding it might not be just an instant fix. Yeah. But yeah, as far as nutrition for urinary incontinence, first of all, fluid intake. It's such a funny thing in LA that, you know, patients will come in with their huge jug of water and be like, I can't stop peeing. Well, you know, part of it is normal. Like if you're drinking fluids, they have to come out. So I kind of talk to them about titrating that water, and as much as we want the glow, like we have to balance it with needing to pee if that's becoming bothersome. But there are other things like caffeine is a bladder irritant, carbonation, artificial sweeteners, and then for some people, spicy foods or acidic foods can be irritating to the bladder. All those irritants become even more so after menopause. So.
And then I have a question about what products, pads, underwear, etc., do you guys recommend for managing leaks when people are going through this process? Is there something that you guys are like, is it on the shelf in Ralph's, or is it something else?
So for urinary incontinence, I think, women are pretty familiar with the different pads and the different sizes and liners and whatever for their leakage. And now there's underwear, just like they have period underwear.
Okay.
They have underwear for urinary incontinence. But there's also a product that goes in the vagina that presses up against the urethra. So it's almost like a tampon. It's called Impressa, and it can be purchased on Amazon or at the drugstore.
Okay.
But it does come in different sizes, but it goes in the vagina like a tampon. So I have some patients who are like, I'm fine unless I go and do, my Tracy Anderson workout or some, high impact jumping workout. So they don't want to have a surgery. They might not want to go through
And that
the
works
whole
for
thing.
them.
Yeah, so they can just do it, for the time that they need that compression. Or if that doesn't work, we have pessaries. It comes from the idea of pessaries that we can insert for patients to kind of press up against the urethra.
Give a little pressure. What about you?
So there are medications that are designed to, if you have urgency and leakage because urgency, there are medications designed to slow down your bowel so you get some time before you need to run to the bathroom. So those are prescription medications. You can take over-the-counter Imodium if, for example, you want to go a big event, you're going to be outside or there are no bathrooms closed, you can take a couple of tablets of Imodium that day for that event, and then...
Which just constipates you so that you can...
Exactly, so it's going to constipate the person, so the stool is going to be more firm, not going to have the urgency to go, and then they can enjoy that social event while we're working on other ways to cope, because we don't want just to change a problem that is incontinence for constipation. So that is one of the things. There are other medications that are not as constipating, but it decreases the urgency to go. And sometimes simple things like peppermint oil in capsules, the one designed to go to the colon, might slow down the colon and
Peppermint oil that you take by mouth?
Yes, so you take a capsule, and those are designed for release in the small intestine and colon, and they are antispasmodic, so you have the urgency to go, it relaxes your colon, so you don't get that much urgency, and then you have time to go to the bathroom. There are plugs, but they don't work as well.
What about bulking agents?
So it
What's
can
a
be
bulking
used.
agent?
So it's like filler, like what we do.
The same
Okay.
that you use for filling.
Yes, okay.
We can do it around the anal sphincter. However, the anal sphincter is a dirty area, so it will help for a little while, but you have the risk of having infections in that area. Sometimes it works better for you, but we have a stool around that area, so it's not as great. Sacral stimulation, even the stimulation in the tibial can help with that. There are little electrical stimulators that you can put in the vagina and actually stimulate the muscles to contract.
Of the sphincter, of the anal sphincter.
And that is something that you can go to Amazon and find them.
Yours too?
Yeah, and they
Which
actually...
is different than what you use.
Yeah, no,
here.
it's something, and even there's one that you can put just in your underwear. It looks like a pad and it sits on the outside, and same thing, it somehow...
It stimulates electrical, and when you do electrical stimulation, it helps, at least for the fecal incontinence, when the muscle is weak or when there are nerve damage, and it helps. So it's better if you do your pelvic floor exercises than just this electrical stimulation, but just it's a good way to do more.
And when you guys talk about pelvic floor physical therapy, because I feel like it's a relatively, well, it's not new, but it's becoming much more common for people to prescribe. What is that? Is that like 3 times a week for 6 weeks, for 12 weeks? Like, how do you guys start that process?
Here's the thing.
Okay.
Here's the secret about pelvic floor physical therapy. I mean, I leave it up to the therapist as far as how many times a week.
Okay.
I think oftentimes, again, back to what's covered, it's like once a week for 6 weeks, but more is better. Just like Claudia was saying, it's the pelvic floor muscles, right? Like you said, they're
Right.
a basket, and it's just like any other muscle. So it works fantastically well when you're going to physical therapy and being compliant with it. But when you when you drop off, as we kind of inevitably do, symptoms return. So it really is something, like going to the gym, that you have to be consistent with if you want to see results. So that's...
But the good thing is that you don't have to spend too much time. You can just turn on the TV and do your exercises.
Because they teach
So
you a
learn,
home regimen.
Exactly. I think once
Exactly.
you learn, right, the idea of a therapist, it's not that you need to continue going to that therapist. Once you learn the exercises, if you're motivated, you can continue to do them yourself. And that's why there are also different devices where you can literally... So biofeedback is something that physical therapists do, where they'll put a probe in the vagina, and as you squeeze it, you will see the pressure on a screen, so you can know, okay, I'm squeezing it adequately or weakly or whatever. And so there are home versions of that, again, that you can buy for, I don't know, $100, $200 online. And you can see it on your cell phone and literally play a video game with your vagina. If you're just squeezing it tight enough, it'll whatever, do the thing.
Right.
And you get that feedback that you're doing it. So much of this has moved to, less invasive, more ways to do it yourself at home.
And more convenient, because going to an office once a week is less convenient to have it at home.
Sure.
And do it
And once you
every
learn how to
day.
do it from a therapist.
And remember, doing the biofeedback or doing the pelvic floor therapy is not only the day that they meet with the physical therapy. You have to do it every day if you want to have effects, and you have to do it for the rest of your life. And we, all women, should be doing some pelvic floor exercises from now on to be continent, and 2, if you strengthen your legs, if you strengthen your hips, if you strengthen your core muscles, when you are elderly, you can get out of chairs without somebody pulling you out, or have to go out this way, and you can walk more straight and have better balance when you are walking that. So there are other benefits to the pelvic floor.
But I do want to say that it can also go too far. So there are some patients who have pain or pain with sex, and that can be related to muscles that are too tight. And so not everyone needs to be doing pelvic floor strengthening. And some people, I send them to physical therapy to help relax those muscles and release those muscles. So there are both ends of the spectrum. I don't disagree with you that, the ideal strength. And now there's this chair that you can, you pay to go sit on this chair, and it, is supposedly the equivalent of doing 1,000 Kegels. But I've had patients come to me with pelvic pain because they got over tightened from that sort of thing. So it's just the right balance.
Moderation.
So
Moderation.
everything in life is moderation. So I will say many people have actually the combination of the both. They have weak sphincters, but they have tightness in the rest of the pelvis, and they can have pain during sexual relationships, and it's not like one is the cause of the other. It can be independent things. So what I'm saying is that most of the time when you had that kind of tightness that causes pain in your pelvis, is not because you over-exercise, it's because your brain is sending signals that tightens everything there, and you are not able to relax. So the pelvic floor therapy, you should be doing exercises for both getting strong and learn how to relax as
I think
well.
that's a really important point. I think people don't realize that a lot of women hold their tension in the pelvic floor. So we always think about like tension in our shoulders, but really a lot of women hold tension in the pelvic floor.
So what percentage of patients, and I'm going to ask you both this, in your practice, so urogynecology, come to you for incontinence?
I would say about 2/3 probably are for incontinence, but I also see a lot of patients for prolapse, for sexual pain, for recurrent bladder infections, and also for pain with urination, something called, that's often related to this pelvic floor tension. We call it interstitial cystitis. That's a talk for another time. But
of those 2/3, and I guess what you were saying is with the two types of incontinence, one is much more commonly treated with surgery than not. But of those 2/3 of your patients, what percentage of those are cured with, or manageable, I guess, with non-surgical intervention?
The vast majority, maybe 80%.
Okay. Yeah, that's good. And so you were saying that a lot of patients come to you and then you find out that they have fecal incontinence, but they come to you for IBS, but what percentage of your patients come to you with incontinence?
I will say that sadly only about 20% of my patients, but I see, I'm seeing motility, so I'm seeing irritable bowel syndrome, I'm seeing constipation, I'm seeing acid reflux, and also some patients with other problems, and just regular patients for colon cancer screening. So although I'm focusing motility, my practice is not just motility.
And so it sounds like there's two peaks in incontinence for both of you. And one is right after childbirth, but generally these are young, healthy women, so they recover, and then it comes back. Is that what you guys are saying?
I think they're able to compensate until perimenopause, menopause, when estrogen levels decline, and then due to the effects on the pelvic floor tissues, they're just no longer able to compensate for whatever. They might have had a sphincter injury or a muscle tear at the time of delivery, and they just are no longer able to compensate for it once the estrogen levels drop. So so basically those patients who might have had a spike and then recovered, or, then it comes back, or some who didn't even have symptoms, they were kind of subclinical, maybe injuries. There's a lot of subclinical anal sphincter injuries at the time of delivery, and some of them
because of stretching or nerve damage, or I guess they're both the same, right?
Muscle tear.
Muscle tear.
There is muscle tear, there is stretching, and there are sometimes nerve damage with prolonged deliveries.
Like with a shoulder dystocia.
Exactly, because they press on the nerves, they elongate the nerves, and then the nerves don't work that fine. But usually the nerves tend to recover that.
At that age.
It's more problematic when you have neuropathy for other reasons, diabetes or the scleroderma, multiple sclerosis, things like that. That nerve is the damage is a little harder to treat, but some of the stimulators, for example, will help. And there is now a transmagnetic stimulation that you do outside. Well, that is a medical thing that also helps with nerve damage in that area.
Are there risks with nerve stimulation?
So it depends if it's implantable or not implantable. So you have experience with that. I have patients that come with me with that, so I know there
Probably been
is a
using it for
benefit,
longer
but you are the
yeah.
one who implants. So problems with the wires.
Yeah, rarely there's a problem, like a physical problem with, an infection.
Does it show like a
It's kind of
pacemaker
like a
does?
pacemaker, but it's in the fat of your butt, so it really
And they are
hardly
getting
shows.
smaller
yeah.
and smaller.
Yeah, they're small. So.
And how long do they last?
10 years, although now they have, I think, some that last kind of like.
There are, you can recharge wirelessly, and they.
You just back up to a charger?
And we used to change batteries before. Well, they used to change because I don't do that operation. They used to change batteries. Then it became rechargeable. So when they were not rechargeable, you will have to change every 5 years or so.
Yeah.
And then they became rechargeable, and now they're getting like a different kind of charge.
Okay.
It's like once a month or something like that. It used to be weekly charging. Now it's once a month or something like that. So it's super easy.
And we didn't get to surgery for you, and I know you do mostly procedural things, but is there a surgery for fecal incontinence, and what percentage of patients get to that?
So yes, there is surgery for fecal incontinence. The first surgery and the only one that I tried to use is the stimulation, because reconstructive surgery, trying to create a new sphincter, is not as easy, and it doesn't work as well. UCLA has a surgeon that does it, but half of the patients might have a good response, and so it's not as good. You can do then the resting and the bulking, and there is non-surgical, similar to what you mentioned about that device in the vagina. For fecal incontinence, there is another device that you can put in the vagina that is called the Eclipse. I don't know why they choose that name. And you put it in the vagina, you pump a little bit of air that compresses the rectum, so you don't have incontinence because the rectum is compressed, so it's shut.
So it closes it down until you release it.
Remember, all these organs, and for us it's easy to understand, but maybe for the people that are listening, the rectum is here, the vagina is, there is a small
3
wall,
millimeters
3
away.
millimeters,
So
exactly. So you put something in the vagina, might compress the rectum. So they do this, and then when you need to have a bowel movement, you deflate the thing, and then you can have a bowel movement, and you can inflate again. But
There's so many ways to treat this, and I think it's fascinating, especially as the slings and the surgeries were so popular. So of the patients who would have gotten a sling or a suspension surgery 10 years ago, what percentage of those can actually be treated with an injection of filler?
I mean,
I know it's a rough. I'm not, but it's curious to me because it makes sense, and it's a good thing to try first, right?
Right, exactly. So we don't have, the long-term data here yet, but it's the kind of thing where it's like, why not try it?
You're avoiding surgery.
Yeah, worst case scenario, you'll end up
And
with
insurance
surgery.
covers this?
Mm-hmm. Yeah.
And
Insurance covers filler.
Exactly.
And Botox. in the right
organ, yeah. So you have an estimate how long it will last, that bulking agent there?
It should be indefinite. Sometimes they need kind of what we call like a top off or a touch up. That's usually pretty quick. But I think once it works, I guess it wouldn't last forever.
It doesn't last
but
forever, but it'll stay for a couple of years, and then you
it
may just
stays
a
for
touch up, not a
years.
full,
Yeah.
not a full dose again, probably.
It's new enough that I haven't run into the repeats, but
Yeah, that's great. Let me just see if there's any other questions.
But I do want to kind of reemphasize
Yeah,
that
go ahead. We have like
the
8 minutes left.
Sling surgery is not something to be feared or avoided. It really is minimally invasive, very effective. It's not.
Can you give
it's
like
gotten
a brief?
Such a bad
I mean, I obviously
rap.
deal with this with implants in my profession.
Right.
So can you just give like a few sentences about what that whole thing was and why it's not as scary as it was in the past?
So all the complications that led to lawsuits and all the commercials on TV, none of those really were related to incontinence slings, period. They were related to mesh that was used in the vagina, but not for incontinence. So, like I said, mesh has been used to fix hernias by general surgeries for decades and decades. It's a safe material when used in the right place. So under the urethra for incontinence is a safe and effective place. Just like, if someone was going to fix
it in the abdomen,
a hernia, right.
Okay.
But I think you have new kind of mesh that is a little more biodegradable.
No, it's not
all kind of the same.
biodegradable. It's polypropylene mesh. It is not biodegradable. It acts as a scaffolding. It is permanent. Your
Same
own
stuff we
tissue
use for
grows.
suture material, basically.
Exactly,
Yeah.
correct. Yeah, and it's we use macroporous and your body's scar tissue grows in there and the sling acts like a scaffolding. So one of the downsides of having surgery is you really have to be careful for the first 6 weeks until it's healed into place, because you don't want to dislodge it, displace it.
When you're saying
So
be careful, so no
no
sex,
super,
no tampons.
no heavy lifting, and really like kind of limited exercising. So
Okay.
just how that's kind of a downside for people for 6 weeks of just being cautious.
And that is so important for the pelvic floor. Heavy weight lifting, when you don't do it right, it can just damage your pelvic floor.
Same with abdominal. We were talking about the core. Same with abdominal work. If you're doing crunches and sit-ups and whatever, without contracting your pelvic floor, you're really pushing against it. The pressure from your abs is pushing against your pelvic floor. So it's really important. I tell my patients, whatever workouts they're doing or Pilates, make sure it's with someone who's really knowledgeable about the pelvic floor and engaging that during your workouts,
Yeah.
even unrelated to going to PT, but that should just be in part of your workout.
Part of your recovery.
Is just part of your exercise
Yeah.
routine is when you're doing abdominals or you're doing
The bridge. I'm going to start doing the bridge.
Yeah.
It's pretty good, yeah. Yeah, I think it's important to see the body as just a complete thing, not just this part is here, that other part. Everything should be
So
kind
do you
of
think for both types of incontinence, is this just a normal part of aging? And why do some people get it and some people don't? Is it all like childbirth related, or what your hormones are, or how much you actually work out and keep all of your muscles strong?
So I'm glad you're asking that, because the stress incontinence is not a normal part of aging. It has to do with either, trauma, weakness to the pelvic floor muscles or the urethra. The urge incontinence, overactive bladder, that really gets so much worse around the time of menopause. And I guess one treatment that I didn't mention is vaginal estrogen. And I think a lot of women think that if they're on systemic estrogen, a patch or pills, that they don't also need the vaginal estrogen. But the estrogen in the vagina really gives a direct treatment to the vagina and the bladder. And it's
plumps up those tissues.
It plumps up those
separately,
tissues,
yeah.
and it makes the bladder nerves less sensitive to everything. It makes you able to hold longer. So all these things really in conjunction. It's, vaginal estrogen plus pelvic floor physical therapy plus maybe a medication or a Botox or a nerve stimulation. So yes, I would say that the urgency incontinence, overactive bladder is more naturally related to aging, and that's the one that increases more with age.
Being sedentary is not a good thing. So
Sitting in front of a computer is bad?
yeah, surprise. Yeah, so being sedentary is not good for anybody. So the more active that you are, the less likely that your muscles are going to get lazy and weak, and your organs are going to start to hand down because there is no support. So exercise helps. But for example, and I should have look at that, the athletes that do heavy weightlifting, they have more rectal prolapse.
Because they're pushing everything down.
Exactly. So
and they're not doing the bridge.
Exactly. We had to go then and come on, let's do it. Let's do it. And people just need to talk to us, and don't be afraid, don't be ashamed. It's a thing that we can deal with, that there are treatments, and that is going to make your life so much better if you can control it.
Okay, I think we are at time. Appreciate you all being here. Again, this will be on YouTube, and so you can share it with friends. Appreciate the comments and questions. I hope I got to all of them. And we will see you in July. All right, thank you.
Bye.